So good morning, I'm Gail Patry. Like she said, I'm the Chief Program Officer at Health Centric Advisors, a member of the IPRO QIN-QIO team. I'm delighted to have the opportunity this morning to introduce my esteemed colleague and good friend, Dr. David Gifford. Dr. Gifford is the Senior Vice President of Quality and Regulatory Affairs for the American Healthcare Association National Center for Assisted Living, which is the largest association representing skilled nursing centers and assisted living communities. His work focuses on assisting providers in their quality improvement efforts and with administration officials on regulations and policies. Dr. Gifford collaborates with Brown University faculty on pragmatic trials, helping to identify, prioritize, and implement studies that rigorously test interventions to improve care for older adults. Dr. Gifford received his MD from Case Western and completed a geriatric fellowship at UCLA, where he also earned his MPH. Previously, he was the Chief Medical Officer at a nonprofit quality improvement organization, where he led the first Medicare National Nursing Home Quality Improvement Initiative, and Director of the Rhode Island Department of Health, where he received the National Governor's Award for Distinguished Service for State Officials. Over to you, Dr. Gifford.
Thanks, Gail. I don't think I've ever heard you say so many nice things about me before, so I'm gonna have to do this more often.
I was always thinking them.
And I like the introduction of working for some unnamed QIO in the past, which was the Rhode Island QIO with you. So, yeah, the QIO QIN program is very dear to my heart. It started where I started my career, and so I'm really glad to be able to talk with you all today. Certainly, I was asked to give sort of a quick whirlwind of what are the lessons learned from the pandemic, what it means for the new normal, what's going to be coming in the future, and then hopefully have time for questions. So certainly throughout the presentation, throw in questions in the chat function, and try to address them at the end or during the presentation. Next slide. So what did we learn during the pandemic? We learned that infection control practices and immunizations work, and when they're widely done and done consistently. When they're not widely used and done inconsistently, they don't work. I'm not sure we need a pandemic to teach us all that, but that's really clear. We also know that our staff working in the sector really deeply care about their residents. They came to work despite not having PPE, not having adequate testing, not having resources, and not knowing really how to prevent the spread of this virus, worried that they were going to bring it home to their family, yet they showed up. We did not see mass people just not coming in at all for that. We did have a lot of people not be able to come to work because they screened positive and they contracted COVID, and we had a lot of deaths. We had an equal number of cases of COVID amongst the workers as we did amongst the residents in nursing homes during this pandemic. We learned that staffing in this sector is a challenge. It was a challenge before COVID, and it got worse during and is now actually at a crisis stage right now. We also know that the care needs of the residents continue during a pandemic, and other emergencies happen during a pandemic. And we saw a number of emergencies around the country with fires, hurricanes, floods, and other various sort of natural events that occurred. And then I think the greatest lesson learned is we really have to rely on each other because outside help is often limited, or it's going to be remote. And how do we work together to try to address that? And I think the QIO program can really sort of provide some of that help and facilitate some of that work. Next slide. I get asked often, how long is COVID pandemic going to go on? How long is COVID here? What's going to happen with variants? COVID is here to stay. We will have this for the rest of our lives, our children's lives, and their children's lives. About 15 to 20% of the general common cold that we get every year is due to coronavirus variants that were probably results of pandemics eons ago. And they just sort of now established. The same has happened with influenza, parainfluenza, RSV, all the different sort of common respiratory viruses that we have. And new variants will continue to arise, just like we have new variants every year for influenza that we need a different vaccine for. We're going to see continued variants. The amount of variants, how severe this is going to be, really is going to be dictated on what our vaccination rates are and how well we comply to infection control practices. The fewer people we have vaccinated, the more replication of the virus, the more it'll spread, the more interactions people will have without following protocols, and then it'll just continue to spread. Hopefully it attenuates over time and it just becomes less virulent, so it just becomes like the common cold. But the challenge with COVID-19 has been the mortality rate is just much higher in this virus than any others. The complication rates, long haul, myocarditis, strokes, blood clots are much higher than in any other common respiratory viruses, even amongst the younger population, but certainly amongst the elderly. We saw mortality rates in the unvaccinated elderly hovering around 20%. 15 to 20%. Now with vaccination, the mortality rates are well below 1%. The mortality rate for influenza continues to be around 5% amongst vaccinated elderly. So influenza is now going to become a worse respiratory virus than COVID if we can get everyone vaccinated as we go forward. Next slide. Many of you have probably seen this graph. This is just showing you the number of cases in nursing homes across the country. In the blue line, we saw that big spike in cases last fall, and then we had the vaccine, and it went down to almost zero. And the number of deaths have gone down, and then we had Delta variant come along. And what you can, the difference here is you can see the death rate sort of always follows the same curve as the case rate in the community up until this fall when the Delta variant came along, and when everyone's been vaccinated, the death rate hardly bunched up. And because the vaccines really work very well. Next slide. This superimposes the number of resident cases with the number of cases in the general population in the community in the red line. And again, prior to the vaccine starting in January 2021, you could see the red and blue line just mirror each other completely. This virus is very hard to control and spreads in the community. Following the vaccination of our residents, our case counts really dropped. And you can see we did not follow what was going on in the community anymore. And even when Delta variant came along, we still had a much lower rate amongst our residents. Next slide. This has impacted the occupancy rate, this pandemic, in nursing homes across the country. This is the occupancy rate from the NHSN data. Pre-pandemic, it was 80%. In May, it dropped to 72%. That's a big drop. It continued to drop, right, and then went down during the wave last year. And then after the vaccination, it's been slowly increasing. With this new Delta variant and Omicron, it has sort of stabilized at 72%. And this is causing great havoc in the facility. One of the reasons the occupancy has also stabilized recently is about 30–40% of nursing homes are not taking any admissions because they can't find staff to take on new admissions. Staffing has really become the major driver of this, but then there are certain parts of the country where the hospitals are overwhelmed and they're not discharging, doing elective surgeries or semi-elective processing, and most of the admissions are coming in are COVID, and so they're not discharging to the SNF setting, and that's affecting the occupancy as well. And this is having a big impact on the ability for the facilities to operate. And I think we're going to potentially see a lot of change of ownership, closures, particularly in the rural areas, consolidations in the facility if the occupancy is not able to come up over time. New slide. As you all know, CMS requires everyone to test on do surveillance testing. It's based on the amount of COVID in the community. In September, they changed the methodology for doing that to be the cases per 100,000. I have the website here at CDC. I highlight Louisiana, and you can see Louisiana has some counties that are blue, where there's no testing required. Some are yellow, where there's testing once a week. And then there's some orange and red that are required twice a week. Most of the rest of the country is still at the red level for requiring twice a week. We had a lot of questions about why do they have orange and red when they both require twice a week testing? That's because when CDC converted this over, there were lots of guideline recommendations, not just from CMS, but within CDC for all sorts of healthcare settings, but also for schools, for businesses that all were based on how much COVID was in the community, and they all were using slightly different ways of measuring it, and they had slightly different thresholds, and it was just very confusing. So CDC went and standardized this and created this 4-tier blue, yellow, orange, red testing system for all the settings, for all types of things, not just for testing, but for mask wearing, closure, opening, different sort of issues. And when they look at the testing at the rate of cases per 100,000 orange or above, they believe it should be 2 times. So that's why orange and red look the same. They're not different. The guidance for CMS currently on surveillance is for unvaccinated staff unless you're having an outbreak. So unvaccinated staff have to be tested at this frequency. How about that? Next slide. We talked a little bit about infection control in the COVID endemic area. Next slide. This is sort of a basic slide, but I've seen a lot of, continue to see a lot of providers get confused by this, and it leads to inappropriate practices that leads to spread of the virus. And that's a misunderstanding of what the incubation period is with the individual. So the incubation period is if you get exposed to COVID, if I squirted COVID up my nose right now, that would be my exposure. The incubation period is how long before I develop symptoms, which is the classic way of thinking about it, or now with COVID, since so many people don't develop symptoms, before they test positive. And so that time window is the incubation period. And each virus, type of virus, has different incubation periods. Some are much faster than others. For COVID, the incubation period is between 2 and 14 days. It's almost impossible to really start testing positive or develop symptoms within 24 to 36 or 48 hours of getting exposed to COVID. But I see a lot of people who get exposed and then test the next day and say, oh, I'm negative, therefore I didn't get it. I don't need to do anything. Well, that's clear. I mean, I would expect anyone to be negative in that first 48-hour window. The average incubation period is about 3 to 7 days, but we've been working with several nursing home chains and CDC, and about 30% of people who get admitted to the nursing home who may have gotten exposed, right in the hospital right before they came in, and they were testing them every other day. 30 to 40% of them were testing positive between day 10 and day 14. And so this is why the new admissions coming into the facility are still recommended to be in isolation for that 14-day window who are unvaccinated because of that long incubation period. Next slide. The other is to think about when are people infectious. And what, as we all know now with COVID, almost every respiratory virus except for influenza and COVID-19, you're not infectious until you develop symptoms. But with COVID, and influenza, you're infectious before you develop symptoms. For COVID, it's up to 5 days. For influenza, it's about 24 hours. And it's why influenza is so hard to control, but it's also why it made COVID so hard to control, is you don't know who's got it. And that has been a real challenge with this. This shows also the orange line, which is the viral load. It's how much virus you're shedding. And, if you're using the difference between the PCR and antigen test dictate on the viral load, the PCR is going to pick up a test at a lower viral load, but it also picks up people before they're infectious and even after they're infectious, whereas the antigen test tends to pick up people during that infectious window. And so that's something that can sort of help sort that out. The other
David, there's a question in the chat about the incubation time for Delta. Is it different than what you're displaying here?
No, so the Delta variant, the reason the Delta variant is more infectious is not because it changed how it attaches to human cells or how it spreads in that sense. What it does is it makes millions more copies of the virus. And so that Gail, if you were infected with the Alpha or the other variants, and I was infected with Delta, I would shed a lot more virus into the community. So if people around me are much more likely to get exposed to the virus for shorter amounts of periods of time and indoor than if they were around you. And we're both wearing masks, but I'm wearing mine a little inappropriately, I'm more likely to leak out virus because I'm just shedding a lot more virus out. And it just replicates really fast and lots of copies. It also tends to replicate more in the nasopharyngeal pathway, which is where it allows it to replicate out a lot more. But the incubation period is the same. It appears to be the severity of illness is the same. It doesn't appear to have any of the changes. The worry about the Omicron is that it appears to potentially change, so it may evade the immune system, so it may attach to human cells more effectively and spread that way. It also may or may not be more virulent or less virulent, and I think we still don't know it. The preliminary data suggests it seems to be a little less virulent than the other versions of the COVID vaccine that are there. Any other questions, Gail? Gail, any other questions?
I think
Not
Gail's
at this.
on
Or
mute.
there's one from Tiffany. The question about the CMS guidelines for testing unvaccinated staff. I think you answered that. No, I'll keep an eye on it.
Okay. On the Delta variant, because you get a lot more viral load, it comes up. People sometimes tend to develop symptoms a little bit sooner, but yeah, it's about the same. You still see people testing positive later on. Next slide. So what does this all mean for infection control? Well, I took the slide. This slide is from the CDC. It was existing recommendations for influenza prior to COVID. So all the black text is what was CDC recommended be done in nursing homes for managing influenza. And you could see, I then just went through and said, well, how would I update this for COVID? And pretty much you just replaced the word influenza with COVID. You changed Tamiflu to monoclonal antibody. We'll now have the oral medications that are coming out. And we added in cohorting. Other than that, it's pretty much the exact same practices between the two. And I think, we know how to control respiratory viruses. Vaccinate people, monitor for how much is in the community, and as it goes up in the community, you take more actions. As it goes down the community, you can be less vigilant. You test people when they have symptoms. During an outbreak, you test lots of people, you cohort them, you make them wear PPE, and you treat people when they have an outbreak. So I think, it's the same thing. Next slide, Gail. And so this is what happened to influenza during the pandemic. This slide shows the influenza rates by age cohort, 0 to 4 all the way up to 65 plus, in the country prior to COVID. And then in 2020, starting in May of 2020, you see it suddenly drop, and we just almost eliminated influenza in this country. And that's because influenza spreads with an R factor, which is how infectious it is, around 1.7. You need a virus over 1 to be sustainable to spread. Give you a sense, measles, which is airborne and probably one of the most infectious, has R factors around 8 or 9. And so influenza about 1.7. RSV is around 2.5, 2.4. That's probably one of the more infectious respiratory viruses. All the rest, adenovirus and everything else, are right around 1.5 type of R factor. The Alpha variant was around 2.5. And so the COVID was really hard to control. So we had to be super vigilant with PPE, hand washing, distancing, wearing our masks, and all the steps we took. And we really upped our game in the country in all settings. And as a result, we almost eliminated influenza. Now, COVID is just harder to control because it's more infectious. The Delta variant, to give you a sense, its R factor is around 4 or 5. It's much higher. And that's why it's been so hard to control. Next slide. This is a slide looking at the seasonality from 2018, 19, 20, and 2021. The black line in there is sort of the baseline rates of respiratory infections that we see. The red line are the percent of deaths due to pneumonia type unspecified pneumonia, which influenza gets captured in there. The yellow bars at the bottom are the number of deaths in the country due to influenza. And the blue solid area are the number of COVID-coded deaths that are there. And you can see that, first thing, if you look at the bottom, the yellow, we eliminated almost influenza deaths in at the end of 2020 and 2021. You can see that the number of pneumonia deaths overall unspecified suddenly spiked, and almost all of them are attributable to COVID. And so COVID really became the dominant factor that was there. Next line. This now looks just at nursing homes. This is an analysis we did at ACA. We took the data from the MDS and the Medicare claims that look at any deaths for any reason at all. And we just charted the number of deaths each week from January 2015 right through the middle of 2021. And you can see that the number of deaths vary from about 8,000 up to 10,000, maybe up to a little more, depending on whether it's in the summer or in the winter. And that's because in the winter, we have influenza, but we also have all the other respiratory viruses, and our population does not do well when they get a respiratory virus. You and I may get sick, we may stay home for a day or two. You have dementia, heart failure, COPD, diabetes, you get these respiratory viruses, you often land yourself in the hospital, and some people die, and that's what this data shows. If you look over to the far right, you can see that right starting in May of 2020, or actually it's April of 2020, right when the COVID started, we suddenly saw a huge spike in deaths. And it crosses over that purple line, which is the upper confidence interval of what we'd expect to see if we're seeing a really bad influenza year or some outlier for the trends. Then we saw it go way down, and then with the Delta variant coming along, or the last fall, we saw the big spike. It went back up again, and I don't have the Delta variant, but it's come way down. And it's actually come way down from normal. You could see during the summer 2020 through October 2020, the number of deaths dropped in nursing homes, partly because the census went down, which was lower, but partly because all the infection control practices we did, we just prevented all sorts of respiratory viruses from spreading, including COVID, and we just dropped the death rate down quite a bit. Next slide. Keep going, Gail. So another analysis we did was looking at, well, what is the relationship of staff vaccination rate to resident cases? There was an article that just came out yesterday in the New England Journal that substantiates the same finding and shows that high vaccination rates, particularly in counties or communities that have high spread of COVID, really prevent a lot of cases. This was national data we used with NHSN data. We characterized the nursing homes based on the vaccination rates of less than 50, the first row, 50 to 80% the next row, all the way up to 100% vaccination rate. You can see the number of SNFs in the second column. We looked at the number of resident cases that week. We calculated the average resident cases per 1,000 residents of that week. We looked at the deaths and the average deaths per 1,000 residents. And what you can see is that when you get over 50% vaccination rate up to about 90%, you cut the number of cases in half from about 0.7 per 1,000 to about 0.3. When you get over 90%, you can cut it down again in half further to about 0.15, and you almost eliminate the deaths at that point. And you get up to 100% vaccination rate out smaller. We've done some more of this as we now have higher vaccination rates everywhere else, and we're seeing the same sort of trends. And I think the study that was in New England Journal found the same thing. You've got to probably get vaccination rates over 90%, probably over 95% amongst your staff if we're really going to prevent the spread of this virus in our sector. Next slide. This is the current NHSN data that you could pull off the the CMS website that's updated every week. This is the average vaccination rates in every state. And you can see there's not a lot of variation in resident vaccination rate. Runs from a low in Nevada of about 73% up to 95% up in Vermont. New England states tend to be a little bit more on the left-hand side of this graph, but not necessarily. You do see some wide range. You see Iowa up in the top area with the group, North Dakota as well. Next slide. When you look at the staff vaccination rate, now you see a lot of variation. It ranges from a low in Missouri of under 60% to Rhode Island leading the country right now. And you'll notice almost all of the New England states, and almost all the states in the top 10, except for Hawaii, have a vaccination mandate. And many of those states were not in the top 10 prior for staff vaccination prior to implementing the mandate. The mandates did work. Next slide. So here are the states. I think one other state has added to it. These are the states that have mandates for either all healthcare settings or just nursing homes or just state facilities. New Mexico is the first state that we're aware of that has added the booster shot as a requirement for the vaccination in healthcare workers. Mississippi was the first state to mandate vaccines for long-term care workers in assisted living and nursing homes. They did it in June. A number of people have looked at the vaccination rates in Mississippi, Louisiana, Arkansas, Tennessee, and Alabama, the surrounding states of Mississippi. They all had very similar vaccination rates in the low 50s. They all increased their vaccination rates by about 3 to 6%. Mississippi went up a little bit more than the other states by about 2 or 3%, but in the end, Mississippi still wasn't over 60%. Mississippi had both a religious and medical exemption, but they also had a test-out option, that if you tested twice a week, you didn't have to get vaccinated. Almost everyone took the twice-a-week testing in Mississippi, and so you saw very little change in their vaccination rate compared to the surrounding states that didn't have a mandate and didn't have a test-out option. And if you look at the number of resident cases and outbreaks, they were identical in Mississippi and the surrounding states. So this is one reason that led to CMS and others, because they were aware of this data when they came out with their rule not to allow a test-out option for healthcare settings. Now that rule, as we all know, has an injunction and is stayed for the time being, but it's a good lesson learned as people are thinking about doing employer mandates, whether you want to allow a test-out option or whether you want to allow a test-out option that phases out over time. You're certainly going to an abrupt vaccination mandate could have impacts on your staffing. Next slide. Which I think the staffing challenges are the big issue. Next slide. So we have all heard about the mass resignation in the country. This is data from the Department of Labor, the BLS, Bureau of Labor Statistics. This is the number of available workforce staff working in long-term care facilities. You can see it was slowly increasing over time, and that's been a long-term trend. And then we had the pandemic hit, and we had these mass resignation. We've just dropped. Now, some of this is due to people being sick, dying. Some of this is due to people downsizing because their census went down. But, we've just had trouble with workforce everywhere. Next slide. This is the same data from the Bureau of Labor Statistics, broken out by different healthcare settings. In the upper left-hand corner is outpatient centers. Below that is physician offices. Then in the middle is home care, hospitals at the bottom, and the far right is nursing homes and assisted living. And what you can see is that staff employments were going up in all the sectors, and then they suddenly dropped during the pandemic. But in the other sectors, they've been able to recover. But in the nursing homes and assisted living, they've not been able to recover. They are way down. And this is really, I think, the biggest problem right now facing nursing homes. As we talk to nursing homes around the country, it's staffing more than COVID or vaccination or any other issue. This is the thing that's driving, I think, all policy and decision makings in facilities right now. And it's probably what makes it really hard to even talk to them about doing any quality improvement efforts or any projects, is they're just so worried about staffing on the shift the next day or Saturday. Next slide. I think I have it on the agency. Oh, let me go back a slide. Sorry, Gail. We've seen a huge growth in agency use across the country, and we've seen agency costs, as you all know, it's skyrocketed. We're now seeing rates between $50 and $75 an hour for agency use when they used to be $15 to $20, $25 an hour. They've doubled or tripled in many parts of the country, and they continue to go up. And many of the agency staff don't show up because they get a job for a higher pay somewhere else. And so for the first time, we're not even seeing agencies show up when they're scheduled. And this is just causing havoc in the facilities. Next slide. One opportunity to think about is to promote this idea of a hallway ambassador or universal worker. This helps lessen the load of the clinical staff, the CNAs and nurses. These individuals can do unlicensed activities. And about half of the call lights and calls that CNAs and nurses get to go to a resident's room do not require CNA or nursing to answer the question. They are, someone wants a glass of water, they want the TV changed, they want a blanket, they want something to read, just a whole host of things. You do not need a licensed individual to do that. Stocking supplies, often when a nurse or an aide or even housekeeping's in a room and they're fully gowned and gloved, they need some support and some additional supplies. You can have a hallway ambassador help bring those to those individuals so they don't have to ungown and undress. One of the leading causes for the F880 infection control tag are people breaking isolation and contact precautions to go and get something out of the room. And so that can really help with that. This can also help keep residents apart. It can meet their other needs. It's a good system to do that. It could be a career pathway to getting people trained to be CNAs. Potential candidates for this are students, high school students or college students who are looking to try to bolster the resume to get into college or get into medical school or some other healthcare, graduate school, nursing, retired elderly family members. You pay them, but this is an opportunity. You don't have to go through the training that are issues. The CNA training programs right now are running at around 50 to 75% capacity in some of our polls. Some states are at 100%. But almost all the sort of temporary people that were hired during this pandemic, if you had them all get their CNA training, we estimate it'll take between a year and 2 years to get through all the available slots and the testing slots in the states, because the states do not have enough testing slots and enough training slots for the CNAs. And we see this coming to a head as a big problem, particularly if when CMS lists some of the public health emergencies around some of the staffing issues in facilities. And so we're going to have to really think about promoting alternative staffing models to get through this crisis, because we're not going to be able to train and identify enough nurses or CNAs quickly to, I think, fill the need that's out there. Next slide. On the regulatory and payments front, next slide. Pretty much, you know, the four things that are driving nursing home care are reimbursement programs, 5-star, survey and regulatory issues, and changing patient mix. You know, I think the growth of serious mental illness and opioid use disorder in facilities is going to continue to grow. That is a population that needs special staffing competency and training, and that is certainly an area that we're keeping an eye on over the next coming years. I think we'll see continued growth and expansion of advanced dementia. One of the populations that's the most hard and most difficult to manage with the home and community-based service waivers that we're seeing is people with advanced dementia, and they just can't. They require 24-hour attendant care. I think we'll see a greater shift coming in the facility, and then with the expansion of home and community-based services, we're going to see, as with every study that has looked at this, shows that the acuity in the facility goes up. And so we'll just have to have better training of staff to look at the higher acuity that are going to be in the facilities. Across all these programs, infection control is clearly the dominant thing that's driving it, but hospitalizations, customer satisfaction, antipsychotic use, function, and staffing are, I think, the main outcome metrics that we hear and are common across all the different programs, 5-star reimbursement and the survey system that's there. So if you're going to be trying to work with a facility, if you're not focusing on those 5 areas and within the context of infection control, I don't think you'll be able to get their attention to work on any projects. try to do a pressure ulcer project right now, I think you'd be laughed out of a facility. Next slide. The number one citation right now is 884, the failure to report to NHSN. There are 7 reporting modules that must be completed. The most common reasons for citation are that not all the modules were completed. So whoever was completing the modules did 6, but not the 7 because they didn't quite have all the data ready, and they forgot to come back to it within the 7-day reporting window. The other would be not all the data elements were completed. CMS does say that if you report any, just a portion of the data in a module, that is sufficient. But we've heard a number of members who have left a few areas blank and gotten cited. So I don't think their algorithm is completely accurate, but we haven't been able to fully verify that. The number one reason, though, is actually waiting to submit on Sunday or waiting to submit on day 7. Because you have to submit within 7 days. We recommend everyone submit at least twice a week. That way, you always will make sure you're reporting within 7 days. We've had a number of people who wait until day 7, and then something happens that prevents the reporting on day 7. I'm sure you've heard many of it from the facilities as well. Literally, it's every dog ate the homework issue, computers crashing, nurses needing to get surgery, car accidents, weddings, deaths, graduations, fires, hurricanes, floods, everything. And CMS has not been too lenient on this. So we recommend that you have at least 2 or 3 people trained because it takes time to get certified, as you all know, in the HSN system. But I would have at least 3 people trained. That way, if that one person is unavailable, particularly on day 7, someone else can pick up the slack. And I'd be reporting twice a week. And that should be able to cut a lot of these issues down. I think CMS is looking at maybe changing also how they do some of this reporting and citation, because the citations and CMPs they've been issuing have continued at a steady clip, and they've not seen any change. So it's not been helping them get faster, more accurate data with what they're doing. I think they're going to look at that process, which will only make sense. Next slide. 880, most common reason for the citations are the failure to consistently pick your favorite infection control practice. Going in and out of the room without, and then fill in the blank, cohorting incorrectly, and then commingling residents on COVID units or commingling staff on COVID units. And so there's a real need to sort of look at, and I think a lot of facilities need help with the cohorting issues. Some do it really well, but a lot of it's because of that incubation period window. A lot of it's not understanding the asymptomatic spread and why you need to take those, what happens when you have an outbreak or what's going on in the community. And that would be an area that I think the QIOs can really help with the nursing homes. Next slide. One of the practices that we're really trying to promote, and I know that Gail and Margie helped develop some of this with Brown. We had reached out to Brown and talked to them. They developed it. They pilot tested it in a couple of states. Is this concept of what's called the shift coaches. These are peers who on each shift, as part of their duties or separate duties, you could use the hallway ambassadors that I described before to fill this role, but they are providing just-in-time coaching and just-in-time feedback to other residents and or staff, staff and or residents or family members. So if they see someone who's wearing their mask over their chin, they give them immediate feedback on needing to wear the mask correctly. If they see a housekeeper not washing their hands or they take their gloves off after donning and doffing PPE, they will remind them with that. And this practice really can significantly increase consistent use. It also gets the staff used to being watched and monitored, which they're going to get when the surveyors come in. It also gets them used to knowing what they're supposed to be doing. So when surveyors ask them what they're doing, they can sort of explain that. It does require you to create sort of a culture of when you see something, say something, and that's not always the culture in a facility. You can use this shift coaches for other things besides infection control practices, but it's a good model that works there. We have the website here for where you can get resources to help the facilities to do that. And Margie could probably explain a lot more to you about that because she was the architect behind this. Next slide. We've been talking with CDC. We have a couple of grants with CDC to try to address infection control practices. And one of the things they have found is that there's a lot of misunderstanding of why infection control practices are needed. I think we spent most of our time as a public health system explaining the how, how to wear the mask, but not why you need to wear a mask. I think, some of the explanations that were in the media and got out there is that a lot of these practices are about protecting you as a person, when in reality, a lot of these practices, like wearing a mask, are principally to protect others, so you don't spread the virus to others. And because of the asymptomatic feature, we're not used to wearing a mask and thinking, only if I have symptoms am I infectious to some other individuals. So understanding the why has been really key, and CDC's been asking us to develop materials to really push that out. We've been talking with CMS and the QIO program there, that as we make this material, we will make it available to the QIO program to push out over the next year, both for families, residents, and staff, and not just clinical staff, but non-clinical staff as well. If you all have any resources or tools or videos on this aspect, we would welcome them now to incorporate them in, because we're right in the process of collecting that, starting to put the curriculum and the material together. There'll be a free online training program that'll be divided into very small, discrete modules. So any help you could have with that, that would be fantastic as we go forward on that. Next slide. Unnecessary meds, CMS in their QSO memo said that they're going to focus on this area. Next slide. This is partly in response to the New York Times article that looked at the growth of schizophrenia in the nursing homes. CMS raised this, probably back in 2015, that they started to see a growth of schizophrenia, and they were concerned that it was clustering in some facilities, and it appeared to be an approach to minimize oversight for the quality measure that excluded people with schizophrenia on the antipsychotic use. We've looked at the data. There's and CMS, and there's a lot of reasons for this. Some of it's because no one really coded schizophrenia before, so there were a lot of admissions of people who had schizophrenia, but their admission MDS did not say it because the family didn't have it, the information wasn't available, or it just didn't really matter for any reason, so it wasn't coded. And then on the subsequent MDS, when people were paying attention for this, they coded schizophrenia. That was one reason. Other reason was that there was more people with mental illness coming into the facility. If you look at other mental illness that's unrelated to antipsychotic use or not involved in the measure, bipolar disease and others, they've all been growing at the same rate as schizophrenia. But that said, there also have been a number of facilities in the country where they have seen a larger number of new admission of people admitted without a diagnosis, not on an antipsychotic, who then on a subsequent MDS have a diagnosis of schizophrenia and a new diagnosis of antipsychotic. CMS started to do a focus survey in 2018 to look at that process, and they were in Ohio, and I can't remember the other state. And what they were looking for was that if a person was to acquire a new diagnosis of schizophrenia, then they would expect the facility to do a PASSAR. They would expect that there would be a psych evaluation, because this is a very hard diagnosis to make in people with dementia and in elderly. It's rare to have new schizophrenia in the elderly. They'd expect to see some documentation of symptoms that distinguish schizophrenia from the other diagnoses of dementia. They'd expect the physician to do a history and physical. In some of these facilities, the physician was giving a oral over-the-phone diagnosis of schizophrenia. So they wanted to see a site visit. This needed to have a change in care plan. It was a new major diagnosis, and with anything else like a new major diagnosis, a notification of family. If they didn't find all of these steps, they were citing the facilities. And I fully expect with that QSO memo that they will dust off this pilot, because they were working on figuring out how to spread it right before COVID. So I would assume that we're going to see this come out in 2022. from CMS. And what the role of QIOs will be in this, I don't know. But as you know, what the way the surveys go, that's what sort of the nursing homes pay attention to. Next slide. For 5-star and Medicare Compare, there will be some changes. CMS has indicated that we thought it was going to happen in October of this year, so it's most likely going to happen in January, February. They're going to update the staffing component of 5-star. I believe they held off on it because of the staffing crisis that was happening, but they're going to add staff vaccination rates to Nursing Home Compare, and then a couple months after that, they will add it to 5-star. They're going to add a staffing turnover and retention from the PBJ data. They're going to add a comparison of the weekend staffing to weekday staffing when it differs, and they're going to. This is going to require them to change how they do 5-star assignment on staffing component. They've not indicated how they will do that. I'm guessing and assuming that they will adopt some methodology similar to the way they do the quality measure component, that there will be points for each of the different staffing measures. So there'll be the nurse HPR den, there'll be the RN HPR den, staffing vaccination rates, staff turnover, staff retention, weekend to weekday, and then they'll get points. They may weight some of these more than others and add up the points, and then they'll assign stars that way. But they're going to have to, they will have to dramatically change how they do the star rating for staffing. And as you can imagine, this is going to get a lot of attention by the providers when this comes out in early 2022. They also said they will probably most likely add the healthcare acquired infection measure resulting in hospitalizations to the component. Other than that, I don't think we'll see many other changes to 5-star in 2022 or going into 2023. Next slide. On the Medicare VAP program, next slide, CMS last year indicated that Congress expanded the VAP program to add in other measures. The VAP program currently puts 2% of your Medicare Part A payment rates at risk based on the 30-day rehospitalization rate. Congress said that CMS has to expand that program to add other measures. They can add up to 10 additional measures at their own pace. Last year, CMS asked for what measures they might consider adding it in. CMS just released the MUC list, the measures under consideration for rulemaking, on December 1st to NQF. The NQF will review those measures, provide recommendations in January, and then we will likely see these in the May payment rule that CMS comes out. In the MUC list, there were 4 measures that were added to the VAP program. One was a customer satisfaction measure. There's a core Q long-stay measure. One was a hospitalizations due to healthcare acquired infections. One was a staffing nurse HPRD that's currently used in 5-star, and the other was a discharge to community measure. And so certainly with 2% of payment at risk, you're going to see a lot of facilities focusing on these measures and needing to do it. This will probably go into effect in fiscal year, maybe 2023, but more likely 2024 fiscal year, because they have to figure out how to redo all the scoring, and they have to do some previews in the statute. The rest of the program, the statute hasn't changed, so they're not going to be able to change much of the program. They'll have to change some way they do the scoring because they have multiple measures instead of one measure, and CMS has not indicated how they plan on doing that. Next slide. So I think, Gail, that leaves us with the 15 minutes for Q&A you asked me to do, or close to it.
David. Actually, I wanted to mention that the IPRO QIN-QIO is doing a webinar on boosters next week, and so we're encouraging people to watch their email for an invite to that. But to that end, I wanted to ask you if you were aware of, or have you been exposed to any particular best practices around boosters, or anything that impacts the regulatory requirements about boosters?
So there's no regulatory requirements around boosters except for New Mexico. That's the only area we've seen any requirement on boosters. The data is, coming out every day on the effectiveness of the boosters. It appears on each piece of the data that in the elderly, the boosters really do work for it. We've done some analyses and shared it with CDC. Others have as well, and there's a bunch of looking at antibody levels going up and down as well. Two things appear to be happening with the Delta variant, which will then apply, I think, to the Omicron. One is if you're over 75 in particular, 65 over, but definitely 75, we see a waning immunity. Antibodies level drop down, and we've seen breakthrough cases go up after about 5 to 6 months. That's pre-Delta. When Delta came along, you see that there is a slight mismatch between the vaccine and the Delta variant. And so regardless of the duration of when you were fully vaccinated, you see a jump up in cases. But you also see a jump up of cases with Delta a higher rate after 5 to 6 months. So there's both a waning immunity, but there's also a sort of a mismatch. Now, most of the mismatch has been on test positivity, because about 90% of the nursing home residents, others who have breakthrough cases with Delta, are asymptomatic. Now, there's been certainly some reported cases. There was a case in Connecticut and a few other states that have had some outbreaks with the Delta variant, where there's been a higher death rate and symptomatic rate. But on average, about 85, 90% of people are asymptomatic or very mildly symptomatic who get the breakthrough cases. And the rate of hospitalizations and deaths does not appear to be higher, but you're just seeing a little bit more breakthrough because I said Delta is more infectious and it overwhelms that sort of immune system. The Omicron is going to be, seems to be the same thing. There, it seems to be more of a mismatch, but the mismatch is, allows more breakthrough cases, but the rate of serious illness and death preliminarily does not appear to be a lot worse, but you hear a real hesitancy because it's really preliminary data and we just don't have enough of it yet. But what we've seen is with the booster, antibody levels go up higher than what you got after the first 2 doses. If you were already infected with COVID in the past and you get a booster, you have really good immunity. That probably is the best immunity anyone has seen, because it not only revs up the antibodies to the spike protein, it revs up all the antibodies that you made everywhere else. We do know that if you just had natural immunity, that you have a much lower, you are more likely to get breakthrough cases with Delta and Omicron. But if you get a booster, it really cuts it down. We've also seen some preliminary data in the nursing home setting that the booster has really dropped down breakthrough cases of both Delta variant and other variants. We don't have enough yet because Omicron isn't been available to see that yet, but it really does work a great deal. So the data, I think we're going to continue to see more data. The booster has a really positive effect. And I think it's why the White House is really pushing it, and I suspect you guys are getting a lot of pressure from CMS. We've had a couple of calls with the White House and CDC asking us to really push it in this sector, and I can't imagine they're not giving you guys the same pressure on it. But from everything I'm seeing, it makes sense, and it makes only clinical sense to do the booster. Because the question is, we just don't want people to get die or get seriously ill. And while it may not prevent you from getting test positive and getting infected, it will work that way. How long the booster works, I was just talking to someone the other day, they said, and I haven't seen this as a secondhand data, that the booster seems to wane after about 3 months. I'm not sure why or where they got the data. I think it was something data from Europe, but I don't know the data on that. But I'll pass along rumors on this call. Why not?
And just to clarify, David, there was a question in the chat. Does it matter what booster you get? Is it dependent on what your initial vaccines were?
You know, there's some subtle differences between the boosters, but there, I would just get whatever you can. You know, what's available. If you can't get I wouldn't wait a long time to get an extra booster. You know, but you also don't have to run out this evening to get a booster. certainly NIH did a trial, and there's another data coming out on mixing and matching. For all intent and purposes, the Pfizer and the Moderna are essentially the same vaccine. Moderna seemed to have a little bit better response than Pfizer. I don't think it's enough that I would mix and match. I personally had the 2 Pfizer, and when I got my booster, I had the option of getting a Pfizer or Moderna, and I stuck with Pfizer. But there are some people who say, well, you get the Moderna, though the Moderna booster is half dose, and all the trials in NIH and others were with full dose. So it's hard to say. If you got Johnson & Johnson, there you need a booster within 2 months. Again, the data might suggest switching to get one of the mRNA, Pfizer or Moderna. But I know a number of clinicians and other people who got Johnson & Johnson went and got the Johnson & Johnson booster. So it's more important to get a booster than to figure out which one you want to do. But you could certainly mix and match. And I wouldn't wait. So if a nursing home resident is scheduling a clinic and the long-term care pharmacy is coming in to do a vaccination, whatever they bring, that's what the booster everyone should get. I would not try to mix and match it. Now, certainly residents have the right to pick what they want, but I recommend getting whatever they came in on the booster.
Thanks, David. Open it up for any other questions.
There is a measure that is on the MUC list that's in the SNF QRP program, which is to require IRFs, LTACs, and nursing homes to report to NHSN for C. diff. And I think all of us have experienced the challenges with NHSN reporting at a level 1 for all the reporting that's due. To do the C. diff reporting, as many of you know, you require SAM level 3. If that goes through and CMS puts it in the rule, that's going to really, I think, challenge the whole NHSN reporting system. And the support we're going to have to do for NHSN reporting will go up exponentially.
Someone else is asking if you're aware of any talk about discontinuing the use of eye protection, as that has been a difficult thing for facilities.
I think, yeah, I talked a little bit with CDC about eye protection. Their view is that when providing direct care, and particularly in individuals who are infected with COVID, eye protection is key. Eye protection tends to act, it's interesting, eye protection seems to work because it prevents you from touching your face and eyes, which has been one of the causes of the spread. But I think wearing just general eye protection around in the facility and other areas, I don't think, I recall right before COVID, in the fall of 2019, CMS came out with the enhanced barrier precautions to really look at multi-drug resistant organisms and C. aureus that was spreading. And they had eye protection in there with that. And so I don't think they're going to fully back off from eye protection, but I don't think it'll be probably as widespread. They will sort of simplify it, hopefully. If you want my slides, I'll send you the slides if you email me, or you guys make them available, Gail?
We will make them available. Thanks for mentioning that.
There is one other question. Can you test positive after receiving a booster?
You can, no. The short answer is no. The antigen test and the PCR test do not test positive from either the Johnson & Johnson, Pfizer, or Moderna vaccines, and same with the booster. You could test positive because you got infected after getting the booster, but you're not going to test positive because of the vaccine.
Thank you. Well, as always, thank you for an excellent presentation, Dr. Gifford. It's always a pleasure to hear you talk and share your wealth of knowledge with everyone.
Well, thanks, Gail. And, I think the role the QIOs are going to play coming out of this pandemic with helping the nursing homes is going to be really key. And so we welcome your support. If you need help hooking up with your state affiliate or state affiliate in the states that you're in, please let us know. Working with them is going to be really key. They have really good relationships with the facilities in the state. If you don't know and have a relationship with the state affiliate, I'd strongly encourage you to reach out to them. If you're having trouble, if they're not responding, please reach out to us and we can help you facilitate that.
Thank you.
Thanks. Appreciate you taking the time today and for all the great information.